Good evening, friends. Today, I would like to welcome Dr. Thadi Mohan. He's our clinical professor and consultant at Amruta Institute of Medical Sciences, and he will be discussing very important topic today on biomechanics of the knee and some OSCEs on total knee replacements as well. Welcome to you, sir.
Hey, thanks, Balu. Is that visible?
Yes, sir, it's visible.
Yes, sir. Yes.
Yeah, so basically, I just thought I'll, share some biomechanics of the knee and TKR with the students. I think you don't need to go into too much detail, so I've tried to keep it very simple. For the postgraduate level, I think, though you must be assisting in TKRs and all that, I think from the exam point of view, you probably don't need to know too much. Anyway, so without further ado, we'll start. So my first slide is on the meniscus. So we'll start off with some basics. So I just wondered if anyone wants to tell me something about the meniscus. I mean, how do you identify which is which? All of us know there are two menisci. Anything? Anyone in the audience? Balu, should we kind of unmute everybody? I'm just wondering so that people can actually join in with the answers.
Yes, sir. It's actually they're free to unmute themselves.
Is it? Okay.
Yeah, yes, sir. Yes, Shyam.
So,
Shyam is around.
Yeah, guys, and of course, girls as well. Anyone can join in. How do you generally identify the menisci? Which is which? Anupam, I can see Anupam there.
Sir, on the axial section, sir. On an axial section,
You're talking about the MRI? Are you talking about the MRI, or is it just the picture?
Sir, if it is if it's 2/3 of a circle, then it is a lateral meniscus.
Okay.
Whereas if it is just a semicircular shape, then it is a medial meniscus.
Okay. Yeah, I think that is fair enough. So in this picture, the A, what has been marked A is what?
Medial meniscus.
Medial meniscus. Yes, thanks, Navami. Well done. So that is got a semicircular shape, and it's larger of the two, and the smaller of the two, in this case, the B, is the lateral meniscus, and it's more circular. Okay, so that's good. And one of the common questions is, of course, what is the order of structures on the middle of the knee? So I hope all of you know that. Yeah, any mnemonic will do.
Medical college.
Lucknow Medical College.
Good, very good. Okay, so what is the content of a meniscus? What is it made up of?
Fibrocartilage.
Fibroelastic cartilage.
Okay.
Collagen and fibers.
Collagen, yes. And surprisingly, water is more than 70% is water. So that is another thing. Okay, next, let us come to any ligaments, important ligaments that you know are attached to the meniscus. Let us start with the medial meniscus. Does it have any important ligaments attached to it?
Meniscofemoral ligament.
Meniscofemoral ligament is attached to the medial or the lateral? Okay, what is coronary ligament? Where is it attached? Okay, so
Peripheral.
yes, so coronary ligament is attached to the medial meniscus. The meniscofemoral ligaments are attached to the lateral meniscus. Can you name someone who said the meniscofemoral? Can you name the names of the meniscofemoral ligament? There are two famous names.
So
Bris-
of Brisberg
Brisberg.
and
Humphrey and
Reisberg and Humphrey.
Okay, great, well done. So next, functions. Can someone tell me the functions of the meniscus?
Access shock absorbers, loop,
Good, well done.
provides loop.
Provide stability to the knee joint.
Joint stability, well done. Yes, shock
Reduces
absorber,
wear and
joint
tear.
stability.
So the physiological locking mechanism is also dependent on.
Yeah, I mean that could probably be in the okay. Takes part in the locking. Okay, so you guys have pretty much touched on everything. So this is the functions of the meniscus. The most important thing is load transfer. Okay, so yes, the body weight is being transferred, as you can see, over a wide area thanks to the meniscus. Let me just try to minimize my window. Okay. So the contact between the femur and the tibia is, the contact area is widened thanks to a meniscus. And if you do a meniscectomy, the area is obviously reduced and the stress is increased. So contact stress goes up. And someone mentioned joint stability, shock absorber, and proprioception as well. So that's about the meniscus. Anyone wants to comment on the line AB and CD in this picture?
AB is the
So
white side.
CD is transponder that line,
Sorry?
and AB is white sides.
Okay, well
CD
done.
is the
AB is white sides.
Yes.
Yeah, so how do these lines help anyone? Say, obviously this is an intra a picture of a total knee while doing a total knee. How do these lines help anybody? What is the importance of these lines? How does white sides line, for example, help? What is the function of these? Knowing these lines, why is it important?
It's for positioning of the femoral components. Sir.
Okay, very good. So the femoral component, the rotation of the femoral component is, is helped by these lines. Now, if that is the case, can you also answer why you put the femoral component in 3 degrees of rotation? Anyone knows why is it kept in 3 degrees of rotation? What is the funda behind that?
To achieve a symmetric flexion space, symmetric rectangular flexion space, and to avoid the lateral collateral ligament laxity.
Correct. Yeah. So why did they decide on the 3 degrees of external rotation? That's what I'm asking. Why not say 10 degrees of external rotation? Why not say 5 degrees of external rotation? What actually made everyone decide that you have to put it in 3 degrees of external rotation? What you said is very right, Ramsey. Maybe you can just clarify again, just elaborate on that.
So native tibia has a 3-degree varus.
Excellent. So yes, and so Naomi, so if that is native tibia, then what happens?
Parallel joint lines.
So,
Correct. Who said that? See, yeah. So now because there is a 3-degree native varus, normally when you cut the tibia, how do you cut it? Do you cut it keeping the 3-degree varus, or do you cut it perpendicular?
perpendicular to the
Yes.
mechanical axis.
Yes. So
Mechanical.
yeah. So exactly. So you have cut it perpendicular, and to make up for that, and what Johnson said about keeping a flexion, the rectangular flexion space, you have to give it a 3-degree external rotation on the femoral side to make it rectangular, and thereby keep the ligament balanced as well. Okay.
Sir, is there any reason for patellofemoral tracking also?
Yes.
Is that one of the
Yes.
reasons to keep it in external rotation of 3D?
Definitely, that too is one of the reasons. It helps in the tracking. So here you are. Everything that we discussed is in this slide. Transepicondylar, posterior condylar axis, and that's why you cannot depend entirely on the posterior condylar axis, because that's where you can have a lot of wear, and if you depend entirely on that, you can get your rotation wrong, because your condyle might be worn, say for example, in a medial OA or a lateral OA, you can have condylar hypoplasia also. So in cases like that, you can't entirely depend on the on one single axis. So when you have a Whiteside's line and a transepicondylar line also to assist you, you can be more sure of getting your rotation correct. Okay, so then there are some axes which you have to know, which is called the mechanical axis. Anyone knows what is a mechanical axis?
Center of the femoral head to center of the ankles.
Okay, and that has to pass through the
center of the knee.
Okay, excellent. So mechanical axis has to pass through these 3 points, and if you have the center of the knee deviating from this mechanical axis, you can call it varus or valgus accordingly. So what is the anatomical axis? How is the anatomical axis different from the mechanical axis? I think I'll show you this and you'll get an idea. Yes. So there you have the anatomical axis is along the long axis of the individual bone of the femur, the tibia. The mechanical axis is an imaginary line. I mean, all these are imaginary lines as well, but you can see that the mechanical axis and the anatomical axis, they differ where the femur is concerned. They're almost similar where the tibia is concerned. Okay, so that is the basis of the valgus resection angle. Is that understood?
Yes, sir.
So the angle that the anatomical axis makes with the mechanical axis is around 5 to 7 degrees. And that is why, since you are cutting it, the distal femur is cut with that much of valgus incorporated into it. And here on the right, you have the mechanical axis. If it is medial to the deformity, then it's a genuvarum. If it is lateral to the deformity, it's a valvum.
Okay.
Yeah, I think many of this you will probably already know. Just going over it to complete the topic. So my next picture, can anyone tell me what do you notice in this picture? I mean, forget the arrow. Actually, that arrow is it's been taken off the web, so arrow is not the important thing. Forget the red arrow. But what do you notice when you see an X-ray like this?
So this is an X-ray of a skeletally mature person who has undergone total knee replacement.
X-ray of a total knee replacement.
Yeah, of a skeletally mature person who has undergone a total knee replacement.
Agreed. Yeah.
We can see the femoral component with the tibial base plate.
Right.
And the lateral view, we can say this is a cruciate retaining processes because there is a peg that is seen. So.
Excellent. Well done. So, yeah, that's what I wanted all of you to recognize, that you have cruciate retaining and cruciate sacrificing, and the way to recognize these processes is that what Naomi said is absolutely correct. You have only the peg here, in contrast to, I have another picture. Yeah, so here on the lateral view, on the other one, you can see that there is a, what is this called?
Cam and post mechanism that is
Yes,
formed under the
so
bed.
that is the cam, and that's missing on the side. So you can recognize a cruciate retaining from cruciate sacrificing knee replacement. And what is this? I mean, sorry, I didn't put the lateral view, but
hinge.
Yes. So this is a hinge joint. So the reason for showing all these joints is we come to the next question. What is constraint? What do you mean by constraint? So if you understand constraint, you will understand, all these knee replacements, that there are various kinds. I mean, what are you trying to achieve by having so many designs? So what is constraint? I mean, what do you understand by constraint in TTL?
So the movement is only in one plane, flexion and extension.
Okay.
Rest,
In where is that? In only one plane?
in only flexion and extension is possible in constraint.
Sagittal plane.
Yeah.
Okay.
Whereas
No, you can have something called unconstrained. Okay. You can have semi-constrained, and you can have fully constrained. Okay. So you might have heard of unconstrained, semi-constrained, and fully constrained, right? So basically what you're trying to do is you are trying to make it as stable as you can, because you are trying to mimic the anatomy of the joint, and you are trying to in certain cases you are trying to take over the function of the cruciate ligaments, right? So when you do a cruciate retaining, what are you preserving here in the cruciate retaining?
PCL.
You're preserving the PCL. In the sacrificing, you're taking it off. So what does a fully constrained knee have, which, say one of these knees doesn't have. See, in a fully constrained knee, let's go back to this. Here you have, an MCL which is absolutely, you can see there's a wide opening here. So in all possibility, the MCL is gone, right? So in wherever your collaterals are not there, okay, so you have no mediolateral stability, right? If your collaterals are gone, your knee can go this way mediolaterally, there will be no stability. So you have to, and if suppose your the PCL is also gone. So in such knees where the ligaments are all gone, where you have to depend entirely on the joint to give you stability, you need something which is fully constrained. So that is where you do a hinge joint. That's what Shyam was saying, that it will give you only one plane of movement. It will move only in flexion and extension. Okay. Of course, you can use a rotating hinge. You can add some rotation into it by using an insert, which will allow you a little bit of rotation. But the implant itself has got an inbuilt stability. Okay. And the joints that we routinely do, the ones that you assist on a day-to-day basis for a routine osteoarthritis, routine rheumatoid, the joints that you do routinely, that's the semi-constrained. Okay. So you have in the cruciate retaining, you have a PCL which is giving you stability. But I mean, in a cruciate sacrificing, you don't have the PCL, but it's got the post and cam to give you the stability. But you're relying here on the collaterals. Your collaterals are intact. If your collaterals were not there, you won't be able to do the semi-constrained kind of knees. So you are assuming that your collaterals are intact, and either you are keeping the PCL or you're sacrificing the PCL. Okay, so that is where constraint comes in. So it depends on the amount of stability the implant inherently has. Okay, what is this deformity?
Windswept deformities.
Okay, so the reason why I showed you this windswept deformity is, let us take one deformity at a time. I just wanted to know what are the things, what are the ligaments, or what are the structures that are released when you deal with a varus or a valgus deformity. Yeah, anyone? Let us start with varus, because that is probably the most commonest deformity that you see. So what are the structures that you know are released when you correct? Anyone? How do you go about, say, let us look at this diagram here. On the right you have a valgus, on the left you have a varus. So what are the structures that you think are released in the process of correction of this deformity?
So in the valgus, the valgus will have to release the lateral collateral, because
Okay.
the medial collateral will be stretched and lateral can go into contraction also.
Okay.
Can be
Yes.
contracted. Whereas
Yes,
in the
very good.
varus, we release the medial but
Capsule.
but whereas we don't release the MCL.
Deep
So
MCL
we
is
release the deep fibers
deep
of the
MCL.
Deep MCL and posterior capsule.
In both or varus?
in varus.
Deep MCL.
Okay. Yeah, good. Then what else? What are the other important structures? One very important structure, say, let us talk about the valgus, the important structure that you release in a valgus.
Posterolateral column.
Cruciates also.
Okay. In both these knees, when, first thing to notice is whenever there is a severe deformity, okay, by severe deformity, I mean anything which is, say, more than 20-25 degrees, valgus or varus. Can you keep the PCL?
No, sir.
No.
Yeah, usually you have to release the PCL as well. Okay, so in the valgus knee, the important structure is, of course, you have to release the capsule, the lateral side. Very important thing is you have to release the iliotibial band. Okay. Then you have to release the lateral head of the gastrocnemius. From the back, posterior capsule, one of you commented, posterior capsule, lateral head of the gastrocnemius, plus minus, sometimes popliteus. So everything on the lateral side is contracted in a valgus deformity. Also, you don't want to release too much on the medial side because everything is stretched. So you keep all your releases onto the lateral side. Similarly, in a varus knee, you keep all your releases onto the medial side because the medial side is contracted, the lateral side is all stretched. Okay, so deep MCL, then posteromedial corner, of course PCL again.
Same membranosus.
Yeah. Okay, so these are the things you must remember. And what are the things you release in a flexion deformity?
Posterior
There is
capsule.
posterior capsule, PCL.
PCL, posterior capsule.
Yes. So this is some of the things, and of course osteophytes. That's very important because you get a lot of osteophyte formation which will be denting all the soft tissue structures. So a very important part of the release or correction of deformity is removing the osteophytes. All of you are aware of osteophytes. What is the reason for osteophyte formation?
Instability of the joint.
Sorry?
Instability of the joint, sir.
Excellent. All right. The next question is you probably have had a peek at it. What are the bony cuts in a TKR? There are 7 bony cuts. Can anyone name them?
Distal femur cuts.
Distal femur, yes.
Distal femur, proximal tibia, anterior chamfer, posterior chamfer.
Box is not considered. No. Yeah. What else?
The patella and one more.
Anyone?
So distal femur, posterior femur, chamfer cuts, proximal tibial cut.
Distal flexion cut, posterior chamfer cut, anterior flexion cut, anterior chamfer cut, posterior flexion cut. In tibia flexion.
Yes, so it is anterior femur, yeah. Distal femur, anterior femur, posterior condyle, anterior posterior chamfers, patella. I mean, of course, not everyone does it, but that is also a cut. And then the tibial cut, proximal tibial cut. Okay, so there you are. These are all the cuts. Okay, I mean, I won't go into this. This is, you'll have to understand this. This chart is very important. I find, you can look at various combinations where flexion is normal, extension is normal, or flexion is tight and extension is normal. So what are the things to be done appropriately? I mean, how do you deal with each combination? I think it's, if you just read it up from a chart, it will probably be easier. Okay, so we'll just have to cover a few slides, so I'll just skip. So what is the Q angle? What is the normal Q angle? And how is it important? What do you mean by a Q angle, Anupam?
Okay.
So it is an angle made between
It is the angle made by the patella over the by the
and the quadriceps tendon.
increasing the pulley mechanism.
The
Extensor mechanism.
How do you draw it? I mean, what are your 2 points which you use to draw a Q angle?
ASI is to patella and patella to tibial tubercle.
ASI is to center of patella, then center of patella to tibial tubercle. Yeah, that's fine. So what is the normal value?
12 to 14 degree in men and 17 degree in females.
Yeah, it's more in females.
15 plus or minus 5.
That's a good way of remembering. Yeah, good one. Yeah, it's around 10 to 20 degrees. So there you are. So so how do you optimize tracking? I mean, flat tracking. See, end of the knee replacement, you would have noticed that everyone wants to make sure your patella is not flipping off, that it is staying in line, it is moving in the trochlear groove. So what are the things that can be done to keep the patella in place and not, the patellar tracking is very important. A lot of patients can have anterior knee pain if your patellar tracking is not proper. So what are the ways in which you can ensure that your patella stays in line with the center of the femur? Anyone has seen patellar resurfacing? Has anyone assisted patellar resurfacing? Or I think most of the Indian surgeons, they don't resurface the patella. Why is that? Why don't we normally resurface the patella? Why do a lot of Western surgeons resurface the patella, and why do Indians don't? Any idea? One of the reasons is the patella has to be, if you resect the patella, you should have at least 14 millimeters of bone behind. So And the other thing is the patella button normally measures around 8 mm. So 14 plus 8, you should have at least 22 mm of bone to start with. So if you don't have that much bone, I mean, many of the Indian patients, the Indian women especially, may have thin bone, and so you cannot really cut too much bone off. So you're worried about fractures and things like that. So a lot of people don't resurface. Of course, if you have a very thick patella, you can resurface it. But if there is a bit of cartilage remaining, most of the people will not resurface it. Okay. So, and then another thing which Navami commented was, the excitation of the femoral component is also one way of ensuring that your patellar tracking is proper. Okay. Okay. So, anyone knows anything about ACL, PCL? How many bundles there are for each? How many bundles does the ACL have?
Anteromedial and posterior. 2 bundles.
How many bundles does the PCL have?
Posteromedial and anterolateral.
Okay, I mean, this can get, this is these two mechanisms I think are very important. The screw home mechanism and the rollback. I mean, it's very important that you understand the screw home mechanism. What happens in a screw home mechanism, anyone? I hope I have not put all of you to sleep.
The lateral femoral condyle reduces back to the tibial sensor.
So basically, in full extension, the tibia will go into an external rotation.
Okay.
And all the ligaments will become taut, and so that is the screw home mechanism.
And the knee becomes very stable, right?
Yes, sir.
Okay.
And on flexion, there is external rotation of the femur and internal rotation of tibia.
Okay. And what brings about that? What is one structure which helps?
The
which not quadriceps, which muscle?
Popliteus muscle.
Popliteus is responsible for that. And which side do you have more rollback, the medial side or the lateral side?
Lateral side.
Yes. So the lateral side you have more rollback. I mean, that is the picture I have tried to put there so that you can remember that. Why do you think that happens? Why does it?
Medial condyle lower.
So lateral femoral condyle, the distal and posterior condyle have different radius of curvature. Medial condyle has uniform radius of curvature. So,
is it just the curvature, or is it any other structures also which contribute? Which is more congruent?
Medial.
Medial is more congruent. Yes. So the medial is more congruent. Your medial meniscus is less mobile, okay, compared to the lateral meniscus. And because of the congruency, there is lesser movement on the medial side On the lateral side, you have more of a convex tibial surface. It's more point contact. You got a very mobile lateral meniscus, and the rollback is much more on the lateral side. Okay, so we'll just touch on this. What do you see? What are the two pictures that you see here? Which is which?
We can insert.
You are seeing an insert and a tibial tray. So, yeah, go on. What is, say, I'll start with this. What is this compared to what is this? How is it different?
So one is a fixed bearing.
Correct.
The other one is a mobile bearing.
Well done. Okay, so you mean which is the fixed one? This one?
Yes, sir. The left is a fixed one.
Okay, so this one, as you can see, it slots into the tray, or it by means of certain locks, the insert is fixed into this tray. And what is the material it's made up of?
Polyethylene.
Polyethylene. Can you
Polyethylene.
qualify that? Is it just polyethylene or
Highly
Highly
cross-linked.
cross-linked
polyethylene.
polyethylene.
ultra?
Ultra high molecular weight polyethylene.
Yes. And what is the tray made up of?
Zirconium alloy.
Zirconium.
Cobalt chrome. Cobalt chromium, sir.
Yeah, cobalt chrome. Yes. So, what are the advantages of, say, fixed over a mobile?
Wear is less
Where? Where is less on which side?
on the polyethylene insert.
In which type, I'm saying?
In the mobile bearing.
Mobile bearing, sir.
Okay, so you are saying the wear is less. Okay, but why don't we keep on using mobile bearing everywhere then, if the wear is less? That is what we want, no? We want longevity. So why don't we use mobile bearing in everything?
So the laxity of the ligaments also.
Is important. You have a point there, Johnsy. Yeah, you just qualify that. You said laxity of ligaments is important. If you have very lax ligaments, what will happen? If your ligaments are very lax, would you use a mobile bearing or a fixed bearing?
Fixed bearing, sir.
Yes. So what can happen which prevents you from using a mobile bearing?
It can pop out.
Yeah, that's
it. And knee instability, sir.
Yes. So, what is that called? What is that pop out called? Is there a term for that?
Dislocation, sir.
Dislocation of the insert, or?
Jump.
Sorry? It can flip, the insert can flip, it can turn all around, it can flip around. Okay, so yeah, so basically your insert can dislocate. So your ligament, you're relying on your ligaments laxity, and you can make a decision. If you feel the ligaments are very lax, you should not be using a mobile bearing. You will invariably you can dislocate your insert, or it can flip. So this picture, of course, I have borrowed it from. Are you guys aware of there's something called a hip and knee book? I think, I mean, if you haven't already read it, it's very useful. At least the basic topics are extremely useful, and it's worth having a look. So here you can see there is more movement certainly possible between in the mobile bearing, but at the same time, you know, it can flip. It has got its limitations.
Okay.
Looks like that is the last we have. Balu, you want to add something?
No, sir. I think you have covered very, very important topics with meniscus, the various axial line, the axes and reference lines, then the coronal plane deformity, the valgus and varus, the structures being released, the constraints, then the Q angle bearings. I think these are the common things which are.
Yeah, these are the topics I think usually that you get.
Yes, sir.
As short notes, or you may be asked on an X-ray to identify what type of knee it is.
Yes.
So I don't think they will, you know, give you very difficult, you know, deformities and ask you to, you know, they won't go into too much of technical details. I don't think it's required. It's a, you know, only at a specialty level. But since arthroplasty is so commonly done, and you should have a working knowledge of what is being done and why it is being done. And I think that should be more than enough. Examination of knee and the various tests, I expect, I mean, all of you must be already knowing it. There's no point going over all that. So I hope it has generated some interest, and I hope it was useful.
Yes, sir. Bipin sir is here. Hi, sir.
Thadi sir, namaskaram.
Hi, Bipin. Were you silently listening and I hope you are taking notes.
Yes. No, it's being recorded, so I can be lazy.
Why don't you add something? I mean, I see most of the things people in my unit would have heard me, you know, saying these things several times.
You know, one of the problems of being a consultant is you don't get to see others operate. You don't get to see others talk also. So this is only learning opportunity for me.
Anything which you feel?
No, I think you covered most.
They should be knowing about.
I think only suggestion for from me to the juniors is you should be asking more questions. You should be answering more questions. I think last time our Prabhagar mentioned this. I think you guys anyway your faces are not there, so you can confidently ask questions.
I noticed that is something which in all Indian PGs, or maybe it's common to Indians, we are generally very reticent to speak. You
yes.
know, when I used to be a resident, a lot of people used to tell me that don't open your mouth and expose your ignorance.
Yeah.
And somehow that got ingrained in us. And it's only when I went abroad, I realized that it is so untrue actually. You know, there are certain things which we have some very bad habits, I think. And I used to notice people used to ask the most what you would have considered a very simple or a silly question, they will ask, in amidst, in a serious meeting, they will ask, what do you mean by this? What do you mean by whatever, rollback or whatever? I mean, something, what is the role of the cruciate ligaments here? Could be anything, and nobody hesitates to ask. I think it's very, very important that, and that is one thing which in exams, all of you, when you're asked something which you may not be familiar with, everyone becomes numb. I mean, they becomes mum, sorry. They don't open their mouth. See, the point is, it should be more of a discussion. You should learn to tackle all kinds of questions. And as you keep talking, things will fall into place. Nobody is expected to know the answers to everything, but you will be knowing something. Unless you start talking, it doesn't help.
I think this is a good platform for them to practice talking, sir. So
I think so. I think
before the exam,
yes.
definitely all of them should try speaking. So this is a very good platform. Even if you make mistakes, there is absolutely no issues.
Yes, certainly. Very, very good point there. All of you should learn to talk, answer. Bipin will give you a few more tips because he's very well versed with the system there. Bipin?
Too long now.
No, but you know the system much better, in a sense. Yeah. You have met all the registrars there, and you know how they.
Yes, I think the first day in my trauma meeting I can still remember because we had this. I was 5 years post. I had orthopedic experience, and we had a Colles fracture, and I think the first year SHO was asked what to do, and he says, "In my opinion, I will do this." And I was shocked. I mean, I would never have thought of saying my opinion or something, But I think there we go. I think we have both these guys are probably time to go to sleep. Okay, fine. Thanks very much, Mohan. Balu, over to you.
Is there anything you guys want to ask specifically?
Please feel free to ask. You can unmute yourself, or you can place your questions in the chat box. We can take it up for discussion. Any doubts? Naomi, is there a question? You want to ask something?
Yeah, yes, sir. I want to know about the thickness of the cuts that we take, sir. Like the distal femoral cut, is it like pertaining to 9 mm itself, or is there any change?
See, the reason why you are taking the cuts is you want to replace it with implants of the equal thickness.
Okay, sir.
Okay, so if you randomly take cuts, you will be also altering your joint line. The level of your joint line will be going up or down, and by doing so, you will be, you will have various problems. You can have, patellar issues. Your patellar can go up and down. You must have heard of Alta and Baha.
Yes.
So, so there are various issues of, taking random cuts. So you have the basic premise of taking the cuts is you are taking cuts and replacing it with the implants of the same size. Okay, so that's why you take, approximately 1 centimeter cut, so 9 mm, 10 mm.
So does it have anything to do with the company which we are using here?
Not usually. I mean, most of their jigs are pretty much similar. You know, there are some aspects to designs. They say this one, someone has got a single radius. Some implant has got a better patellar tracking. So there are a few changes like that, but by and large, if you look at their jigs are pretty much the same.
Sir, how does the cuts differ in each of the deformity? If there is an FOT, do we go for an increase in the distal femur cut?
You should, I mean, you take the usual cuts. I mean, there is a difference in the valgus resection angle with deformities. For example, you know, you use a 5 to 7 valgus angle in, say, a varus deformity, but in a valgus deformity, you keep it, you know, you take it even less. You don't give that much valgus. You just give minimal valgus, say 3 degree or something like that. And also, to a large extent, you should try to do your soft tissue releases and correct most of the deformities. Then you titrate according to, you know, sometimes you may need to take a bit more of the femur or a bit more of the tibia according to the residual deformity. In certain cases, you have to, if for example, if there is a hyperextension, you may have to use, you know, bigger implants, or you should be more conservative with your bone cuts. If there's a already hyperextension deformity, you don't want to take off a lot of bone and make it even worse. So there are some, you know, finer points like that. But,
hello, sir.
Anupam, yeah.
Sir, does the bone quality have any influence on the decision of doing a TKR or not?
Sorry, bone quality.
Sir, the bone quality of a patient, because most of these procedures are done in pretty elderly people, and they might have severe osteoporosis and issues related to that. So does the bone quality have any influence on determining whether we should go ahead with the replacement or not?
You have to be a bit careful when it's very osteoporotic bone. You have to take extra precautions. You know, you may have to use things like adding a tibial stem or a femoral stem to give it more stability. But the basic replacement protocol will be the same. I mean, you will still take your cuts, you will still do your releases, but you have to be more careful because you can have what are called periprosthetic fractures. You know, if the bone is very osteoporotic, you can't go about banging it very hard. You can break it. So you have to be careful in very osteoporotic bone. You have to be more gentle. Is that what you were alluding to? Sorry.
Yes, sir. I would also like to ask whether is there any case where we will go against a replacement in such severe osteoporotic individuals?
Against replacement? I mean, you said you won't replace. Is that what you're saying?
Yes, sir. Because of the quality of the bone. Is there any situation like that?
Not really. I mean, as long as see, for example, if you look at inflammatory arthritis like rheumatoids, psoriasis, things like that. So in such inflammatory arthropathy, there is a lot of osteoporosis or osteopenia, but you still do replacements there, right? The only thing is, they say in such inflammatory arthropathy, you should not use a CR knee. You should not use a cruciate retaining knee because many of the ligaments are pathological in such inflammatory arthropathy. So there's a very high chance that your PCL will get degenerate, or it will, it will be weaker than usual. So it's you cannot do a CR knee in inflammatory arthropathy. They would advise a safer bet, they would say, is to do a PS knee, cruciate sacrificing knee, rather than do a CR knee. So you can't do a CR knee in very severe deformities as well. That's what I told you. If it's a very gross deformity, you won't think of doing a CR knee because all the ligaments there are either stretched, damaged, and you can't rely on the PCL there. So you have to again use a PS knee. So that kind of thing is there.
Yes, sir.
But purely because the bone is osteopenic or osteoporotic, I don't think you will say, this patient doesn't need or we cannot do a total knee replacement. Okay. Like, steroid patients on steroids, like RA patients and all, very osteoporotic. But you still do replacements in them, right?
Yes, yes, sir.
Yeah. So I think we have had a reasonable discussion. I don't want to drag this on. Guys, get on with your rest of the night. Have a good night and see you tomorrow. Is that okay?
Thank you, sir. We all got a very good idea regarding biomechanics of the knee, as well as very critical points regarding total knee arthroplasty, sir. Thank you so much for accepting our invite.
I just want to take it up because thanks to Bipin for inviting me to take a class. Yeah. Thanks, man. Anyway.
Thank you, sir. Thanks, sir. We learned a lot.
Good night. Good night, everybody.
Good night.
Srinivas. Srinivas,
Good night,
thank
sir.
you. Thank you,
Thank you, sir.
Srinivas.
Good night.
Good night to everybody. Bye.